Hi, this is Nick Fogelson. I'm a physician in Portland, Oregon, part of Northwest Endometriosis and Pelvic Surgery, and I wanted to talk a little bit about neuropelveology. You may be seeing this on YouTube, or you may see it at the bottom of our page on neuropelveology. So up above this video is a whole bunch of text which you may not have read because it's really long. So I just wanted to kind of put it in video form a little bit if you'd rather hear it in that way. Neuropelveology is a field that I am a part of. I'm certified in sort of the first level of three levels of training in neuropelveology, and will be getting the second level of certification sometime early next year, so in the next few months, and maybe eventually we'll do the third level as well. And basically, neuropelveology, I would call it a reapplication of knowledge that every doctor had when they were in medical school and since forgot. Basically, when we go through medical school, we learn in excruciating detail every single nerve in the body. We are required to remember what their names are. We're required to be able to identify them on a cadaver. We're required to be able to recite from memory exactly what every nerve does, how sensation gets from certain parts of the body to the brain, how signals from the brain get to different organs. This is all stuff that every single doctor mastered in their first or their second year of medical school. And then what happens is they forget every bit of it because that information is basically not used unless you go into neurology, and if you go into neurology, you probably have to learn it again. What neuropelveology is kind of a relearning of all of that nitty-gritty that every doctor learned in medical school, and then an application of that information to the clinical situation that we find ourselves in as doctors who take care of women with pelvic pain or men with pelvic neurologic issues. My particular field is mostly involved with endometriosis, but I branch out into mostly women, maybe even men at some point, with pelvic pain issues. And in the end, as neuropelveology applies itself to that issue, basically what it is a way of thinking about pain that is a little bit more detailed than it would be than you would without the neuropelveology way of thinking about it. And by saying that, what I mean is that when people have endometriosis as a source of pain, the typical way that an endometriosis expert or experienced endometriosis surgeon deals with endometriosis is that we do a laparoscopy, and an experienced endometriosis surgeon will be able to identify both the obvious endometriosis and subtle endometriosis, and anything that is endometriosis, they're going to generally resect it from the pelvis, and hopefully that's going to make a substantial impact on someone's pain. And while a patient's symptoms may help us to think about where the endometriosis may be, I think for the most part people are doing a laparoscopy and just removing all the endometriosis that is there. A neuropelveologic way of thinking about pelvic pain is, rather than saying I'm going to go in and operate and remove all the endometriosis, it is a way of asking a patient exactly what they're feeling, where they feel it, where it goes in their body, when they feel it, and what it feels like, and then adding on a detailed neurologic exam where we evaluate how the nerves in the abdomen and the pelvis are working. And that means some of that is in the pelvis, but most of it is in the legs, because most of the nerves in the pelvis actually are going to the legs. And we do a very detailed exam, and a lot of times when people have pain in a certain area, we can also find that the nerves that carry that pain is not working quite right. And that shows up in their neurologic exam. And then sometimes you can get imaging that will find specific findings that indicate certain nerves are dysfunctional. And then when you go to surgery, if you choose to go to surgery, you're not going just to say, I'm just going to remove all the endometriosis, but there are specific nerves that are carrying this pain, and I'm going to address those nerves specifically. There are times when that approach leads us in a different direction than we would go if all we were doing was removing endometriosis. I'll give you an example, which I list above. I had one patient that had extensive endometriosis surgery and got a lot better in her pelvis, but she had a recurrent pain in her epigastric region, which is up here. And a lot of doctors were completely had not sure why she had this pain. And she had her gallbladder taken out, she had a colonoscopy, she had an endoscopy in her stomach, and nobody knew what was wrong with it and basically told her she was crazy, or that, well, you have this pain, but we have no idea why. Well, from a neurologic point of view, this area right here could actually be a lot of different things, and a lot of those things aren't here. When we're dealing with a visceral pain, which means a pain of an organ, then pain will be dull and aching and generalized. It won't be in a very, very specific location. A somatic pain is exactly where the pain is occurring. If I cut my finger with a knife, I'm going to have a somatic pain right here. And right where the pain is where the injury is for the most part. Now, there are some exceptions to that, which we can get into, but a somatic pain is sharp and localized at an area of injury. Anywhere along the nerve you can injure, you can also hurt there, but that's a side thing. But in the end, a somatic pain is where the injury occurs. A visceral pain is generalized. It kind of is a dull, aching pain. And what we find with visceral pains is that there's only 5 or 6 places visceral pains can get into our spinal cord and get to our brain. And these are these big nerve plexuses. We have 2 in the pelvis, and then about 3 as you get up in the chest, and then up in the neck, and then you have the brain, really. And so this person was having a pain right here. That's either the superior mesenteric or celiac plexus. And you know that wherever the pain's coming from, it has to be something that is innervated through those plexuses. And in her case, she ended up having a really big endometriotic nodule in her cecum, which is in the ascending colon on the right side. From the outside on laparoscopy, you could barely tell there was anything wrong. And for that reason, just looking at it with a laparoscope, most people would have not done anything because it looked very normal. But neurologically, her symptoms told us there was disease there. And we ended up finding out that there was disease there, and when we did the appropriate surgery, she was completely cured of this disease. And so that's a sort of patient that the standard approach to endometriosis surgery may not have led to her getting better, but a neurologic way of thinking about it led to a different outcome. You'll also sometimes I had a patient with irritation on the outside of her leg, and she had a kind of a tingling on the outside of her leg. Neurologically, we know what that's being caused by. It's being caused by the lateral femoral cutaneous nerve. She had a very specific pattern of this pain, and so we did endometriosis surgery, and we actually dissected out the path of that nerve. And in addition to removing all the endometriosis, we dissected out the path of that nerve. And sure enough, there was a small fibrotic lesion around that nerve that we never would have seen without having thought sort of thoughtfully about where she was having this pain. And so we have these edge cases. What I have found in my career doing endometriosis surgery is that many people get better from endometriosis resection surgery, but some don't. And when you apply the neuropelveologic way of thinking, you will expand the number of people that we can figure out and who we can help. It is a very difficult field to understand. I by no means have mastered it. You have to think very deeply and in a very detailed way about a very complicated physiologic process. It's a little bit like trying to solve a puzzle where you're putting together all the little clues, and almost like a logic puzzle where, you know, Jane has blue shoes and Jack's neighbor has a red bird, and you know, people with birds, you know, don't have green shoes or something like that. And then you add up all these clues and you come up with the answer. And neuropelveology is like that. You have all these little rules, and so you have a lot of little things you find on a physical exam. You have a lot of things you find in the history. And in some patients, all those things kind of come together and they tell you exactly what's wrong with them. And if all you ever did was think, well, the pain must be in the location where they feel it, or the problem is in the location where they feel the pain, then you would miss it. But if you think about it in a neurological way, then sometimes you find it. Now, some neuropelveologic issues have very clear approaches to fixing them, and some do not. Just because you understand better why someone is in pain does not necessarily mean that you can fix it. And that's one of the problematic things. I have talked about neuropelveology online a bit, and a lot of people contact me and ask me, hoping that I can fix the problem that hasn't been fixed to date. And what I would tell you is that a subset of those people, there may be something that we can do. But only the fact that you understand why someone is in pain better than you did before you thought about it this way doesn't necessarily mean that you can fix it. But there are certain things we can do. If we identify that, for example, the pudendal nerve is a source of pain, We can go down an approach of doing pudendal nerve blocks. We can do physical therapy. And in some cases, we can even do what's called a pudendal nerve decompression surgery, which is a surgery where we release the pudendal nerve just like a carpal tunnel release would release the median nerve in your wrist. For a person that has carpal tunnel syndrome, the pudendal nerve, or any nerve in the body for that matter, could potentially be released from fibrosis or something that is compressing it or injuring it. And for selected patients, that can be beneficial, but not necessarily beneficial for everyone. But that's a very detailed surgery that I learned over the course of studying neuropelveology that not really that many people know how to do. But I mean, there certainly are people that know how to do it. Furthermore, endometriosis that's very, very deep into the pelvis that involves sacral nerve roots or the sciatic nerve directly is endometriosis that a lot of people are not really understanding how to remove. These are techniques that were really pioneered by Dr. Mark Possover, who is really kind of the founder of the whole neuropelveologic movement. And these are very, very technically difficult surgeries that I am starting to do. They're very challenging, and I always think very, very carefully about who is the appropriate people to operate on for this kind of thing and who is not. And in some cases, a patient may even be referred to say, you know what, you probably have significant endometriosis right on your sciatic nerve, and I'm not the right person to operate on it, and you probably should fly to Switzerland and have Mark Possover operate on it. I've made a couple of those referrals. Over time, as I continue to study this area and continue to do more and more of this kind of work, I think this practice will expand to the point where we can do anything that can be done in Europe. But right now, neuropelveology as a surgical specialty, that it is centered in Europe. It is not in the United States. There is a very limited number of people in the United States that have done the formal training. I am one of those people. But the number of people that have done a lot of detailed neuropelveologic dissection surgery is quite few, and they're pretty much all in Europe. I have done some of these surgeries, and I'm getting better at them. But in the end, I limit myself to doing what I think is safe and what I think will be helpful for the patient. And what I have always said as a physician in medicine is that you put yourself on the edge of the envelope of what you're able to do, and that's what makes the envelope grow. When we do things we train very hard to be able to do things, and then we go attempt to do them, we grow our envelope of what we're good at. And so that's the area where I am. Typical endometriosis surgery, including bladder, complex things, is no longer on the edge of my envelope. Neuropelveologic surgery is on the edge of my envelope. And so when I see those cases, we study them very hard. We make sure that we can safely do them and that we think we're going to do a good job with them. And if we do, then we do it and attempt it. And if we don't, then we potentially refer a patient to Europe if they want to pursue that. It's a very, very interesting field. There's a lot more that you could say about it, of course. But just in short, it is a different way of thinking about pain. It is a more detailed way of thinking about pain, and it can lead to potential procedural things that we can do that aren't so generalized. They're very specific. They're saying there's a specific neurologic injury that has occurred that we think that we can resolve either surgically or non-surgically, and that specificity opens up the range of people that we might be able to help. Because my experience has been that if we take this big block of people that have pelvic pain, maybe like this many of them we're really able to help, and this many of them we do everything we can, and they still don't seem to get as much better as we'd like. And it would be great if this entire block could be cured with neuropelveologic techniques, but I think really it's like this, that with just standard endometriosis surgery we help this many, and then there's a small slice of people that can really benefit from a neuropelveologic way of thinking and therapies, and then there's still a slice of people that we're struggling with. But the more we study and the more we work hard, the bigger we're going to expand that, and hopefully we can get to where we really can help everyone. And that's why I still do this, why I find it interesting, and it's something worth being passionate about and trying to learn, because every additional person that we can help is another contribution that one can make to goodness in the universe, that someone is less miserable in their life because of something you've learned. So that's why I study it. It's very fascinating. I will be studying it further in the first quarter of 2020. I'll be traveling to Paris, I believe, or Germany, depending on where they do it, where we're going to be doing direct work with Mark Possover, and that will lead to the level 2 neuropelveology certification. The level 3 neuropelveology certification involves actually shutting down my practice and moving to Zurich for 3 to 6 months and apprenticing with Mark Possover. And I may or may not do that. We'll see. But thanks for listening. If you have questions, people can always contact my office or send me an email at nfogelson@nwendometriosis.com. Thanks very much. Bye-bye.